Good morning everyone, respected teachers, dear colleagues. Today I will be talking about the distal radioulnar joint injuries, the basic concepts. So this is a common clinical condition. Distal radioulnar joint injury is a common clinical condition, but at the same time it's a commonly missed condition also. What happens is when a patient comes with a trauma or a distal radius fracture, we will be concentrating more on the distal radius component and we will be seeing what the tilt is, how much it is displaced, and we will start missing the DRUJ component. So if you start missing, this may lead to chronic instability and later it leads to an arthritic condition. So once it has led to an arthritic condition, so it may warrant a palliative surgery. So there is a high index of suspicion from hereafter not to miss the distal radioulnar joint injury. So coming to the anatomy, it is a synovial pivot joint with the shallow sigmoid notch articulates on the circular end of the ulna, and the function is basically a pronosupination and the load transmission. So as you can see, the radius of curvature of sigmoid notch to that of ulnar head is in the ratio of 3:2. So that is like a large head in a small socket. So osseous anatomy is only providing minimal stability, and the main stabilizers are soft tissue stabilizers. So that is mainly the extrinsic stabilizers and the intrinsic stabilizers. The extrinsic, as you can see, the pronator quadratus muscle, the extrinsic RP ulnaris and the interosseous membrane, and the intrinsic stabilizers which together forms the triangular fibrocartilaginous complex that includes the TFCC, the dorsal and palmar radioulnar ligaments, the meniscal homologue and the sheath of ECU. So as we have already told, there is a minimal component from the osseous anatomy. So there is one more thing that you have to focus, that is the shape of the sigmoid notch. The sigmoid notch shape also has implication onto the DRUJ instability. There was a Tollett et al. Study, and he proposed that there is 4 shapes of the sigmoid notch, basically a flat face, a ski slope, C shape and an S shape. And he found out that the flat face was found to be more common, and also the flat face is inherently more prone to instability and is less responsive to treatment by soft tissue repair alone. So like next time when you are getting a CT for distal radius, so you have to look one more additional point. What is the shape of the sigmoid notch? So if the shape of the sigmoid notch is like a flat thing, so you are going to do a thing that is inherently prone to instability. So there should be some emphasis given to the DRUJ also. So coming to the diagnosis, the DRUJ injury always requires a high index of suspicion. These are the main 4 tests that can be done for the diagnosis of DRUJ. But the problem with the DRUJ test is, if it is associated with a distal radius fracture, we won't be able to do all these 4 tests. The only test what we can do is an anteroposterior test or the ballotment test, that is intraoperatively. So once you fix the distal radius, you can start doing the anteroposterior stress test or the piano key sign. So that is having a specificity of 94% and a sensitivity of only 24%. The test with 100% sensitivity is the modified press test, that cannot be also done on an acute setting. We will go into details of each test. So this is the ulnar fovea sign. What you have to do is patient wrist and forearm has to be kept in neutral position. Then you can see a soft spot between the ulnar styloid dorsally and the FCU tendon volarly. You will see a soft spot. So you start touching on the soft spot with your thumb, and if there is pain, that is an indication of a TFCC injury or a foveal disruption of the deep volar or dorsal radioulnar ligament. Next is the piano key sign or the anteroposterior stress test or the ballotment test. This is the one test that we can do intraoperatively. So once you fix the radius, then you can start doing this. So how to do is, you firmly grasp the distal radius with one hand, hold the ulnar head with the other hand. So this is how you have to hold. Then you apply the anteroposterior force. So you can see how much translation is there. So CO et al. Has classified this translation. Grade 0, that is normal stability. Grade 1, if there is less than 50% translation, we call it as partially unstable, and if it is more than 50%, we call it as unstable. So ideally all unstable and partially unstable has to be fixed. So this is the ulnocarpal stress test. This also cannot be done on acute setting. Elbow is kept in 90-degree flexion, neutral forearm rotation with maximal ulnar deviation of the wrist. Then an axial load is applied while passively supinating and pronating, as you can see here. Then an axial load is applied. There will be a reproduction of the pain. It indicates an articular disc tear or an ulnar impaction syndrome. Then this is the modified press test. This is the test what we told. It is having an 100% sensitivity. We tell the patient to rise from a seated position in a chair with the assistance of both hands and wrist. So this is how the hand has to be kept, and he is told to get up from a seated chair. This is known as modified press test. So the radiological evaluation, the important thing is you have to get a postero-anterior view. It's not a wrist AP view. You have to get a wrist PA view and a true lateral view. So these are the findings what you will get in a PA view and a true lateral view. In case of a PA view, you will be able to see the widening of the distal radioulnar space of more than 2 mm, and in the lateral view there is a radioulnar distance of more than 6 mm. It has to be measured between the most dorsal cortex of the radius and most dorsal cortex of the ulna. That is from where you have to measure. So I specifically told a true PA view and the lateral view. So what is the importance? So if you are taking an AP view, so the ulnar styloid will be not in the ulnarmost portion. So there is a chance of missing an ulnar styloid base fracture and you won't be able to see the fovea. So instead what you have to do is, you have to get a true PA view. So you will be able to see the ulnar styloid base along with the fovea. Similarly, the lateral view is also very important. You should get a true lateral view. According to the Mino et al. Study, he has described that if there is just a 10 degree of supination or pronation, the subluxed DRUJ may appear reduced, or a dislocated DRUJ may start appearing subluxed. So a true lateral view is also of prime importance. So how you know whether your X-ray is a true lateral or not? So the next time when you are seeing an X-ray, the first thing that you have to see is whether it is a true lateral or not. So you have to follow the SPC relationship, that is a scaphoid pisiform capitate relationship. That is, the palmar surface of the pisiform is visualized midway between the palmar surface of the scaphoid and capitate. So this is the first thing that you have to see before looking the fracture or before looking the injury or the carpal instability. You should know whether it is a true lateral view or not. So there are some indirect signs also. If there is an ulnar styloid base fracture, there is an indirect sign that there is an avulsion of the TFCC. If there is a 50 degree or more of dorsal tilting, a radial shortening of more than 4 mm or a radial inclination of less than 0 degrees. So MRI can be also used basically to diagnose the TFCC tears. The problem with the MRI is MRI can generate many radiological findings. So if you start seeing an MRI, you can see an articular disc injury there. So you have to see what the patient presenting complaint is, and you have to start treating the complaint and not the MRI. So treatment will be basically focusing on the distal radioulnar joint injury that is associated with the distal radius fractures. So first thing what you have to do is, you have to do an ORIF of the distal radius through a Wohler-Hendrix approach. So once you reduce it, then what you have to do is, you have to start doing the anterolateral stress test. Ideally it has been told, it has to be compared with the contralateral side, but intraoperatively it won't be possible. So what you have to do is, before starting your surgery, you assess the contralateral side and you just have an idea how much is the translation on the contralateral side. Then you compare it. If it is a partially unstable or an unstable, that is less than 50% or more than 50%, then you go for fixing it. So how to fix this? You fix it with a 1.2 mm K-wire transversely placed proximal to the sigmoid notch. You should not include the sigmoid notch. The K-wire should be passing proximal to the sigmoid notch. So the K-wire has to be passed, and the K-wire will be usually retained for 3 weeks. After 3 weeks, you can remove the K-wire and range of motion exercise can be started. If it is associated with an ulnar styloid fracture, so this is another common condition what we see. We will be seeing a distal radius fracture associated with an ulnar styloid. So we want to know what should we do with ulnar styloid, should we leave it? So what the literature says is, if there is not fixed, there is a 60% chance of affecting the wrist movements later on. And it's ideal to fix the ulnar styloid fracture. There are various techniques described. You can do a close pinning, a tension valve, even a screw can be used to fix the ulnar styloid. So this is another thing, LAC fracture. This is also one thing that we commonly see is, you have to do an ORIF of the radius. Then once you fix the radius, then you start assessing. One thing you have to make sure while assessing is, you have to do the anteroposterior stress test in 3 positions. That is neutral, supine or prone. So you should know in which position it is stable. Then you start fixing it with the K-wire. And the last, we'll have a note on the arthritis. If there is a long-term instability, it leads to arthritis, then it warrants some salvage procedure, mainly the Darax procedure, where there is a distal end of ulna or a saw Kappanji, that is, the radioulnar joint is fused and a pseudoarthrosis is created proximal. And there is one more newer thing, which I don't have any personal experience. DRUJ arthroplasty has been developed. There is a separate component where you can replace the entire DRUJ. So this has also been developed now, but the long-term results are still awaiting. So coming to the conclusion, So DRUJ injuries, patient presented with an unlacerated wrist pain. Clinical examination provide information of anatomical structures injured. Investigation includes plain X-ray and MRI. Treatment includes splintering, ORIF, repair of torn ligaments and TFCC. In late arthritis, sandwich procedures are also considered. And DRUJ arthroplasty is emerging as a treatment in case of arthrosis of the joint.